Greetings from Pune. I'm Dr. Sanjay Kulkarni. So I welcome the delegates attending this webinar today on Uro-Oncology section, and it will be conducted by none other than our editor of IJU, Dr. Rajiv Kumar. And we have 4 young guys who are going to discuss about robotic-assisted radical cystectomy, and second article is about partial nephrectomy. So uro-oncology is a very important section of the USI, and I'm happy to start these proceedings. So over to Dr. Lakshman Prabhu, our Honorary Secretary of USI. Lakshman.
Good evening. I'll be brief. There was a time when we had journal clubs in the seminar halls of our departments when hardly anything happened. Today, we are so much connected that even the authors can log in. If you request the authors, the principal authors perhaps, or you can write to them that we discussed your article. We had the joy of corresponding with the author. The next day, we discussed your article in our journal club. So that's the beauty of it. And the second thing is, as far as my memory goes, that in recent times, we've never had a journal club at the national level. I think Uro-Oncology section deserves to be congratulated for this. And having Dr. Rajiv Kumar is nothing but joy. I think let us get started and listen to the articles. Thank you very much. And I wish a great time to all those who are logged in.
Dr. Amit, sir. Sir, unmute.
Good evening, everybody. I welcome everybody to this rather innovative idea of ours. I think it is very important, and we've been able to muster the strength captained by no other than Professor Rajiv Kumar, who has kindly agreed at reasonably short notice to host this. This is a culture that we want to inculcate, and I'm actually curious what the response to this is going to be. It's a modern day and age. People's ideas are actually changing and evolving in directions hitherto unknown. So the culture of journal club is something we want. These are serious discussions, and we would like to encourage the juniors. 7:30 was the time. I even mistook it, but the usual time is 8 o'clock. But maybe that is the reason why we're having a little less participants. But I'm hopeful that by the time we end, we're going to have a robust discussion. There is a lot to learn from Rajiv Kumar and the faculty. So I hope they don't miss this opportunity. Over to you, Rajiv.
Thank you, Dr. Ghosh. Ravi, you wanted to say something?
No, sir, I'll be saying it then. Thank
you. Perfect. So thank you, Dr. Ghosh, and members of the oncology section of the USI and the USI itself. Before we begin, I'm going to give you a very brief overview of what to expect in the next 1 hour. Journal clubs have 2 purposes. The first purpose is to learn the subject. So when you read an article, you're expected to learn the subject and the content of the article and what the author wishes to convey. That's one part. But an equally important part is to understand the methodology of the article and to be able to do a critical appraisal of what has been said. What does this mean? Is this just jargon? What this means is you should be able to understand that has the art study been done well? Can the study actually claim the results that they're claiming or the conclusions that they're claiming? Are the results valid? Are they applicable to my circumstance? And what is the value of this paper in the overall literature that's available? So a journal club serves 2 very distinct purposes. Unfortunately, what happens in many journal clubs, not just in India, but around the world, people just read the article, try to take back a message from the article and believe that we've done a journal club. That's not a journal club. That is something that you would also do in a seminar. In a seminar, somebody will come and speak on a topic. He will quote 5 or 6 studies, and you will take home a message from that seminar. A journal club is more than that. Not only do you take back a message, you also have to justify that the message is valid. And the validity comes from saying that I've looked at the study, I've appraised the study, and I think the study is fine. So over the next about 1 hour or so, maybe slightly less than 1 hour, we will look at two articles in this format. We have two teams, two people in each team. One of them will begin by presenting the basic summary of the article. The second one will also then summarize the second half of the article. And one of the two of them will also then present a critical appraisal. Then we will invite the other two panelists who are speaking on the other article to give comments, maybe ask questions. If there are any questions in the chat box, we'll take those also. And then finally, we'll summarize what's good, what's bad about the article, and what's the take-home message from the article. And we'll do this for two articles, so about 20-25 minutes for each article. So let's begin. I would like the audience also to keep questions available. If they have any, put them in the chat box. If you have any questions, I'll take them on your behalf and pose them to the panelists. I will not do a lot of speaking after this part. The bulk of the speaking will be done by the panelists. I will simply be moderating it for them. So let me invite Dr. Sukhdev to present the first article. Dr. Sukhdev, it's all yours.
Good evening, sir. Good evening, one and all. So I'll be discussing about this. Can you see my screen, sir? Is the screen visible?
Yeah, your screen's fine. Just go ahead.
Okay, sir. So I'll be discussing about the IROC trial, which is published in JAMA in 2022. So I'll be briefly giving an introduction and the rationale behind this study, and the methods of this trial design, and the results and analysis of this trial. Bladder cancer is basically an aggressive tumor with disease-free survival of around 60 to 70% at 5 years. And radical cystectomy is the current surgical standard for muscle-invasive non-metastatic bladder cancer. But it has got a considerable morbidity of around 30 to 70%, and also a higher readmission rates of around 20 to 30%, with even ERAS protocols incorporated. So now, since the robotic platform is currently being widely adopted across the globe because of the minimally invasive nature of the surgery, it's a less morbid, which has got a smaller incision, and the suturing techniques are all becoming faster. It also expedites the recovery. Till date, there are only 4 prospective trials which compare the benefit, pros and cons of robotic and open cystectomy. But before I briefly discuss about the trials which compare robotic and open cystectomy, I would like to discuss about the trifecta, pentafecta, and bladder cancer, like how we have in partial nephrectomy and prostatectomy. In 2015, Aziz had first proposed 5 variables which were considered the trifecta and pentafecta. And the trifecta was negative soft tissue margins and lymph node yield of at least 16 lymph nodes, and no clavin and no complications of grade 3 or higher within 3 months. And time between diagnosis of muscle invasion and cystectomy should be less than 3 months. And there should be absence of clinical recurrence within 1 year. And this was a pentafecta. And in 2020, Kakyamani had slightly modified what Aziz had proposed, and he had taken off the time to treatment, and he had included absence of urinary diversion related long-term sequelae in the pentafecta, which is more relevant because, as we all know, that cystectomy has got 2 components. One, the extirpative component where we take out the bladder, and the major one is a urinary diversion component. The extirpative component is primarily related with the cancer-free survival, and it's actually the urinary diversion which has got more to do with the morbidity of the surgery. And Kakyamani had internally validated as 2 groups, ileal condy and neobladder. And among these, neobladder had got better lymph node yield and better soft tissue margins, and other 3 variables were better off in the ileal condy. Now I'll be discussing about the 4 prospective trials comparing robotic and open cystectomy in brief, with all these pentafecta in mind. The first one was by Nix et al. In 2010, which had their primary objective was to compare the lymphatic yield between robotic and cystectomy and open cystectomy. And they had given the result of that robotic cystectomy had a similar lymphatic yield between when compared to open cystectomy. But robotic cystectomy had lesser complication rate of 33% when compared to open cystectomy. And since it was a single center short study, their clinical and oncological follow-up was lesser, and quality of life analysis was not included in this trial. Then came Bauchner's trial in 2015, which was also a single center study done in MSKCC over a period of 4 years. Their primary outcome was to compare the complication rates between the robotic and open cystectomy, and which was similar between the 2 groups. And the other oncological outcomes of negative soft tissue margins and lymphatic yield was also similar. And since it was a short-term study, their oncological follow-up was not included. And with regard to urinary diversion related sequelae, there was no difference between the two arms. Next came the CORAL trial by Khan et al. In 2016. It was a UK-based one over a period of 4 years. It was also a single center study. But interestingly, this study had taken 3 arms: the robotic, open, and laparoscopic cystectomy. And their primary objective was to compare the complication rates between these 3 arms. And the laparoscopic cystectomy had the least complication rate of 32%. The robotic and open cystectomy complication rates were not statistically significant. Then the other oncological outcomes were similar, but the negative soft tissue margins were better off in the laparoscopic cystectomy group. And with regard to urinary diversion related sequelae, there was not much of a difference between quality of life, and the recurrence-free survival was also similar between all 3 arms. And next one was the most impactful till date, the RAZOR trial by Parekh et al. In 2018, which was a multicentric US-based one in 2011 to 2014. Their primary objective was to compare the progression-free survival between the robotic and open cystectomy group. And they had told that they had found out that the progression-free survival was similar between the 2 groups of robotic and open cystectomy, which was around 70%. And there was also not much of a difference in quality of life, and their complication rates were similar. But the problem is all 3 trials had taken extracorporeal urinary diversions, and there was no intracorporeal urinary diversions included. So the extracorporeal urinary diversion is the cystectomy being completed robotically, and they make an incision similar to what we do in an open cystectomy, and they finish the urinary diversion extracorporeally, which actually negates the effects of the minimally invasive robotic cystectomy. So then came the intracorporeal urinary diversion, when people started learning the intracorporeal urinary diversion, which had a slightly steeper learning curve, but robotic platform had made the intracorporeal suturing a bit easier. And so intracorporeal urinary diversion was increasingly adopted. And also the specimen was retrieved through a smaller incision in supra-pubically, and there was decreased bowel exposure and theoretically lesser electrolyte imbalances. So before IROC trial, there were only 2 retrospective series which had compared intracorporeal cystectomy with the open and the extracorporeal urinary diversion. The first one was in 2016 by Tan. Their primary objective was to compare intracorporeal and open cystectomy with regard to oncological outcome of clinical recurrence. And their recurrence-free survival, cancer-specific survival, and overall survival was similar between the intracorporeal urinary diversion and open cystectomy group. And their urinary diversion related sequelae and clavin endo complications were not recorded. And the other one was by Ahmed, which was a retrospective, but it had head-on compared between intracorporeal and extracorporeal urinary diversion. And their primary objective was to compare the complication rates between the intracorporeal and extracorporeal urinary diversion, which is not different. They were at similar complication rate of around 18%. So then came the prospective IROC trial, which was a UK-based one conducted over 9 centers in the UK. And it was sampling was stratified random and block randomization, which was stratified by center and the type of urinary diversion. The recruitment happened from March 2017 to March 2020, and their final follow-up was on 23rd of September 2021. So their primary objective was to compare the number of days alive and out of hospital within 3 months from the surgery, that is patients who are undergoing robotic cystectomy and open cystectomy. The number of days alive and out of the hospital was a surrogate marker of the length of hospital stay. But since most of the cystectomy patients had higher readmission rates, they felt that days alive and out of hospital, which will be much more relevant when compared to the length of hospital stay. So they had taken days alive and out of the hospital as a primary outcome. And they had around 20 secondary objectives, which they divided into recovery-based, perioperative morbidity, and oncological outcomes. So among the recovery, the functional recovery was assessed by a WHO questionnaire, disability questionnaire, and they had a cystectomy specific URTC questionnaire. The quantified activity levels were actually measured by a exercise tracker like a Fitbit, what we wear in our wrist, which they had given to the patients, and they had assessed at specific time points about how much steps they on an average take per day after the cystectomy. Next one was a 30-second chair to stand test, which assessed how many times the number of patient can stand from sitting to standing in 30 seconds. And perioperative morbidity was assessed by Clavin window scoring, readmission rates, intra and post-operative transfusion, length of days in ICU. Non-oncological outcomes were recurrence-free survival, location of recurrence if so, and overall cancer-free survival, number of lymph node yield, and positive margin rates. And out of all these secondary outcomes, the conversion rate from intracorporeal to open or intracorporeal to extracorporeal urinary diversion were not properly assessed, and they have not published the results also. And because it had longer operative time of around 6 to 7 hours, surgeon fatigue was also assessed by a separate electronic tool, which they had not published. So the inclusion criteria, all patients who were aged 18 or above and had non-metastatic bladder cancer and who had or had not received neoadjuvant chemotherapy were included. And they had to have N1 disease or lesser, and ECOG performance status should be 3 or lesser. They had excluded patients who had prior abdominal or pelvic surgery or pelvic RT, and patients who had had synchronous upper tract tumors or who were pregnant were also excluded. So the intervention was, the extirpative component was the removal of prostate and seminal vesicle in men, uterus, fallopian tubes, and vaginal wall with or without oophorectomy in women. And the specimen extraction was through vagina in women, and a separate small suprapubic incision was done in men, and the specimen was retrieved suprapubically. And the lymphadenectomy was for an extended template, and reconstruction was either a neobladder or an ileal conduit. So the Da Vinci robotic platform was used across all the centers, and different models were used. And surgeons should have completed at least 30 robotic cystectomies and sole operators, and they should have been accredited by the British Association of Urological Surgeons. They should have done at least 10 robotic cystectomies per year with a length of hospital stay less than 2 weeks, and they should have had 90-day post-cystectomy mortality rate of less than 5%, and they should have submitted at least one unedited video of the intracorporeal urinary diversion to the BAUs. So this was the schema proposed. Patients were screened and consented, and they were randomized to intracorporeal urinary diversion and open cystectomy. ERAS protocols were incorporated, and they were discharged home, and they were assessed at specific time points 1, 3, 6 months, and 12 months. So these were different assessment timelines, but each and every point of time they had a baseline recording on the day of cystectomy, on before discharge, on first week, 1 month, 3rd month, 6th, and 12th month. Different secondary outcomes were assessed at different time points. So they had predicted a 2-day difference based on a British BAUS national data set from the robotic cystectomy group of 2015. So they had converted the log of 2-day difference into a log scale of 0.22 units. And with a 5% significance level and 80% power, 160 patients per arm was planned. So because it was a surgical trial, not many patients will be keen to accept robotic or open cystectomy. They had planned for an interim analysis in 1 month. And after interim analysis in 1 month, they had found that the trial was going good. So they had increased the sample size to 170 per arm. So this was a participant flow, and 1,121 patients were non-metastatic bladder cancer, out of which 783, around 70% were excluded. And many were not fit for cystectomy. 98 had concomitant upper urinary tract disease. And around 19 had preference for open. Some patients had particular preference for open cystectomy. Some had preference for robotic cystectomy. Some had declined participation. Some had declined randomization, or they had received prior radiotherapy or radical radiotherapy. So out of the excluding all those things, 338 were randomized, and 169 were randomized to robotic cystectomy, and 169 were randomized to open cystectomy. Out of the 169, 157 underwent robotic cystectomy as planned, but 12 did not undergo robotic cystectomy. And out of the 12, 3 underwent open cystectomy instead, and 1 withdrew from the study because he had received a robotic cystectomy outside the study. 8 did not undergo a cystectomy at all. And among all these, 3 had missing or incorrect date of follow-up, and 2 withdrew from the follow-up. So in the primary analysis of days alive out of the hospital, 156 were included, and 161 were included in the analysis of complications of and survival outcome, including the patients who had underwent the open cystectomy and robotic cystectomy out of the study in the robotic arm. And similarly among the open cystectomy group also, 20 did not undergo cystectomy, and 7 underwent robotic cystectomy in the open cystectomy group, and 13 did not undergo any cystectomy. So 149 were included in the primary analysis after excluding the missing or incorrect date of follow-up and people who had withdrawn from the study. And 156 were included in the analysis of complications and survival outcome. Next, Dr. Aditya will be speaking about the results.
Aditya, you'll have about 8 minutes to complete so that we can have some discussion.
Kindly unshare, Dr. Sukhdev.
Sure,
I'll
sir.
just.
Sure. Go ahead.
So I'll be discussing the results, discussion and the conclusion part. I hope my slides are visible. Okay, so this is what in a nutshell is the IROC trial, and this is the visual abstract which was published by them. Basically, as just to recapitulate what Dr. Sukhdev had said, they randomized patients with the bladder cancer, which was non-metastatic to begin with, into a robotic radical cystectomy arm versus an open radical cystectomy arm, and the primary outcome being a very unconventional one rather than which we usually see in oncology trials. Number of days alive and out of hospital within 90 days of surgery, with a lot of quality of life parameters or patient reported outcome measures in the secondary outcomes. And the predetermined 2 days was determined primarily based upon the purchaser's policy, which they have mentioned in their article. And these purchasers are basically driving their funding their robotic program. And that is what they were able to achieve. And this was the results. Coming to the basic demographic parameters, it was a classical bladder cancer cohort. You can see majority of the participants being men, about 80%, mean age being around 69 years, and more than 80 years age patient was about 6%. Majority of them were current or ex or reformed smoker. About 71% of the population was smoker. About 45% of these patients received neoadjuvant chemotherapy. And interesting thing to note was that other pathologies, which they have referred to as variant pathologies such as plasmacytoid, sarcomatoid, or squamoid differentiation, and many others, were slightly higher in the open radical cystectomy group. However, they have not given any p-values or confidence interval for comparison, but they have mentioned that participants were balanced for patient and disease factors. And by disease factors, we mean that the pathology outcome, also the stage-wise distribution, that is muscle invasive bladder cancer or a high-grade cancer, and no residual tumors, that is pathological T0. When they looked at the outcome of positive surgical margins, lymph node yields, and metastatic lymph nodes, they were also comparable. And about 89% of these patients underwent ileal conduit as compared to neobladder. When we looked at the complications occurred in almost 2/3 of the population, both in the robotic and in the open cystectomy arm. But there was a stark difference in terms of the wound complication and thromboembolic complication. As compared to the robotic group, you can see almost 17.3% of the patient had wound complications. And similarly, thromboembolic complications were to the tune of about 8.3% as compared to 1.9% in the robotic arm. Now, this was the primary outcome, which primarily they have stated as days alive and out of hospital within 90 days of surgery, which primarily means once the patient comes for a cystectomy, if you are going by a robotic approach, he's going to stay in the hospital for about 8 days, let it be primary or a readmission. And on the other hand, an open radical cystectomy patient is going to stay in the hospital for about 10 days. When we look at the readmission rates, it was about 32% in the open group as compared to 21% in the readmission group. And when we look at the death within the 90 days, there were 4 deaths in the open group as compared to 2 deaths in the robotic group. Now we come to the secondary parameters, which are basically the quality of life parameters, as he has shown that they have used nursing staff for getting these self-administered questionnaires. They've used Fitbit for doing the step tracker. However, they have mentioned in the limitation that they were not able to have complete feedback from the patients in the open as well as the robotic group. So they had different questionnaires for covering each quality of life parameter. Like for general quality of life, you can see at 5 weeks, there was a significant difference between the robotic and the open group. They had a cancer specific quality of life measure, which was the EORTC quality questionnaire. And they had a difference at 5 weeks and 12 weeks, but that again, at 26 weeks, there was no significant difference and it almost reached the baseline. When we look at the disability and physical activity, again, the physical activity was significantly different between the robotic and open group at 5 weeks and 12 weeks only. At 26 weeks, again, almost 90 to 93% of gain of disability was there. There was no difference between the mean steps per day in the robotic and open group. However, there was a significant difference from the baseline at 5 days and 5 weeks. Similarly, that was for the maximum steps per day. And they mentioned in the discussion section that it is almost like a patient has aged from about 60 years to 85 years. For the stamina, they had done a 30-second chair to stand test. And this was again significantly different between the robotic and the open group at 5 weeks and 12 weeks. Now we come to other important outcomes, which as oncologists, as urologists, we are interested. The procedure statistics, the mean operative time and blood loss was comparable. However, slightly higher blood loss, about 550 ml median loss in the open group as compared to the robotic group, and median operative time was slightly higher in the robotic group. However, they have done an intracorporeal diversion. When we look at the survival statistics, you can see the recurrence rate was comparable between the two groups, 18% in the robotic arm versus 16% in the open arm. And this is at the median follow-up of 18.4 months. All-cause mortality, we had earlier seen the 90-day mortality. When we look at the complete mortality at the median follow-up of 18 months, it was again comparable between the two groups. We look at the Kaplan-Meier curves between the two. This is the recurrence-free survival and the overall survival. This is again, you can see there was no statistically significant difference between the robotic and the open group. You can see the recurrence-free survival graph slightly separating at the end. However, this was not significantly different. However, recurrence rate were a little higher in the robotic group. Coming to the discussion, a lot of discussion in this study is built in around RAZOR trial and the randomized trial, as Dr. Sukhdev has earlier shown. And they have categorically told that the outcome which they wanted to found was a statistically significant more time out of hospital than those receiving open surgery. And they have attributed it to the conventional and the usual attributes of robotic-assisted surgery, which is smaller incision, high definition vision, favorable ergonomics to improve the outcomes. Earlier trials have shown lower blood loss, faster operative times, better health-related quality of life, open conversion. They have themselves stated this. And you can understand that this trial is particularly not adding on to what earlier trials, except being a multi-centric trial. Much of the benefit from robotic operation occurs immediately after surgery, they have stated, and that particular benefit from reduced surgical morbidity is what I found that was one of the parameters which they have come out with. Now, RAZOR trial, we already have a published 3-year follow-up of RAZOR trial, which has shown no significant difference between the robotic and open arm in terms of progression-free survival or overall survival. But the trial did not focus in the post-operative recovery, and this is what they built upon to show in the IROC trial over and above the RAZOR trial. Surgeons with RAZOR trial, as mentioned by Sukhdev, that they have used an extracorporeal urinary reconstruction. So the IROC trial are countering that. They are doing an intracorporeal reconstruction, which reduces the number of incision, making it faster, more efficient. The secondary endpoints, they have stated that they are likely to be more of exploratory because of the type 1 error which have crept into it. And they all favored robotic surgery at 5 weeks. In the disability score, as I mentioned, to simplify it, they have shown that at 5 weeks, it's equivalent to that comparison of a 65-year-old man as compared to a 50-year-old participant in the robotic group. Similarly, the 30-second chair to stand test, which tests the stamina, is similar to having a patient with COPD. The greater mobility was observed in the robotic surgery group, which is agreeable, and that has been contemplated in reduction the rates of thromboembolism. The limitation as cited by the authors are primarily that the trial has to close early because adherence to in-person measurement of endpoints was compromised because of the COVID-19 pandemic. The primary outcome included medical events like readmission rates, the quality of life parameters, which are prone to bias because of the involvement of the unblinded clinicians. The trial was primarily conducted at the high volume hospitals, and therefore its generalizability to a low volume center is questionable. Again, as mentioned, adherence to wearable activity tracker and use of the health related quality of life questionnaire was lower in the open surgery group, and the duration of follow-up for oncological outcomes was short and long-term follow-up is needed. However, I agree with the conclusion that among patients with non-metastatic bladder cancer undergoing radical cystectomy, the robotic group with intracorporeal diversion as compared to open group resulted in statistically significant increase in days alive and out of hospital over 90 days. And they have themselves stated that the clinical importance of these findings remain uncertain. Coming to a brief critical appraisal, the strengths of this study primarily being it's a randomized control trial. It's very difficult to control randomized control trials, especially in a surgical population comparing two arms. They have concentrated on patient-reported outcome measures rather than the survival parameter. It's a multi-centric trial, and they have shown stark difference in early complications as compared to the survival or the overall survival benefit. The limitations primarily remain. There is an inherent bias. Major centers are adept and well versed with robotic surgery. Even the inside information is that the centers were doing robotic surgery exclusively, and open surgery was being done only in cases where they were enrolled in a trial. And if you look at the conflict of interest or disclosure statements, the robotic consumables were supplied at no cost by Intuitive Surgicals. Almost 5 to 6 authors have stated that they receive research funding and payment of proctorship from Intuitive Surgicals. Although this is beyond this thing, but still it can cause an inherent bias. The primary outcome, which is a clinical relevance, is questionable of that, because if you're looking at 2 days difference between out of hospital or in hospital, for us particularly is still questionable when we look at in terms of oncological outcomes. More relevant outcomes like recurrence-free survival and overall survival, the follow-up is short. Variant pathologies, I mentioned it was higher in the open group, and no new evidence is added. And there was a lot of typo errors for our article being published in JAMA. It was a take back for me. And there's a good banter if you look at the letter to editor, because a lot of letter to editors were published on this randomized trial. One of the article which was published in European Urology by Scrolari Cost from Greece, he said that we believe that we should carefully evaluate the outcomes of this study, as in our opinion it is underpowered, it adds no new evidence, and importantly the primary outcome is clinically insignificant. To what Dr. Cato and Dr. Kelly has replied, that we believe that the better quality of recovery is valued by patients, clinical staff, and purchasers, given the frequency and impact of complications and readmission on the patient experience and healthcare costs. So just for getting the relevance of this article, I conducted a small survey on Twitter, and to my surprise, almost 128 votes were received across globe. And you can see that relevance of this article is what you are going to push: robotic cystectomy versus open cystectomy. So the response was 55%, yes, maybe within 5 years, but there were 29% of the patients of the participants saying no and never. And regarding the applicability, this is the statement from Kasiamani on this Twitter tweet itself. Kasiamani was the one we were discussing. He gave the pentafecta, and he has stated clearly that each center, region, country, and healthcare system has different possibility and needs, and resources must be allocated properly. And that's what I think should be the applicability of this trial. Thank you so much for your patient hearing.
All right, thank you, Aditya and Sukhdev. Both of you have done a very good job of compiling this manuscript. We're slightly over time, therefore, a quick word from the other two on the panel first. Ashwin and Vikas, do you have anything to add?
Yeah, it's difficult to assimilate that there was 32% readmission rate in the open cystectomy group, which is usually not seen in our clinical scenario. Has the author described what were the reasons for readmission?
Yeah, they have given a list of individual readmission in the supplemental file. In wound infection,
most were gastrointestinal complications.
Most were GI complications, correct.
Yeah.
I just want to add that what sets apart this study from the previous studies is they have really made an attempt to look at quality of life measures early on after the surgery, which I think is the way forward, because most people, I mean, the robot seems to have achieved what it claims to do: earlier return, earlier recovery, at least from the measurements that this study has done. So I have nothing else to add. I think Dr. Aditya has really covered it along with Dr. Sukhdev.
All right, then I'll give you a couple of questions that are in the chat box. The robotic surgeries were done by people who were pre-qualified as high volume or as experienced. Was there any control for how the open surgeons were trained? Were they high volume open surgeons as well? Is there any data to say that in the papers?
I think Dr. Sukhdev will take that.
They did not mention anything specifically about it, sir.
Yeah, they didn't specify the training required for open surgery.
Yes.
Although I do know that since this is a UK trial and it's an NHS-based study, all cystectomies have to be done by people who have a certain high volume. Otherwise, you can't do it. UK has a system of concentrating a specific type of surgery in a specific type of center. So I'm assuming they would also be high volume. The second question was there any comparison of surgeon fatigue? So although you did mention it in the results, Aditya, maybe you would like to say that. Ergonomic comparisons.
So they are not published. surgeon fatigue. They had used a specific tool called LSX. I think it's an add-on extension to the Da Vinci, which they had not fully analyzed.
Yeah.
They had specifically quoted that that was difficult to analyze. I don't know why it was.
All right, excellent. So we've got the summary of the questions that we had. Now let me just summarize what the take homes from this study that to my mind are. First is the critical appraisal. My biggest criticism for this article is the rationale behind the article. They intended to do this study to look for a 2-day difference in readmission rate. They designed the study for that and they conducted the study for that. It's a very well done study. It's a very difficult study to conduct and they've done a very good study. When the design was to look for a 2-day difference, when they found that 2-day difference, why do they then say we don't know the value of this paper? In the conclusion, they themselves state we don't know what is the value of these results. You designed the study for these results, you found these results, you did 300 subjects, you got the results you wanted. Then why do you say we do not understand the value of these results? To my mind, that is hedging against criticism. Criticism because you know that the primary reason for design was to get funding for this procedure. To my mind, there is some background lack of funding for robotics, and they're trying to prove to the payers or to the insurers that we are going to save you some time in hospital, and therefore you should fund it. Which is fine. If that is your objective, that you're simply trying to say that we can save you money by having 2 days short, and therefore now insurance will start paying for it, be bold and say that was our only objective and we've proven it. When you designed a study for a purpose, you found the purpose to be fulfilled. Why do you limit your conclusions by saying we don't know the value of this paper? So that to me takes away from the paper. You are a little scared of saying to your scientific community that it's only 2 days. I don't know how valuable it is, but then that's what I did it for. Then why be embarrassed about it? So that's one criticism that I have for the study. And therefore the clinical criticism is correct. Does that 2-day really make a difference to the large majority of people who are doing it? I'm not going to get into that debate. I'm not debating for or against. That's a criticism of the methodology and the conclusions. The second criticism I have, of course, is about the fact that your operating time was only 4.92 hours for robotic versus 4.5 for open. Means you really are very well trained. 4.5 for open is something I think 70% of urologists in this country would achieve. 4.5 hours for an open cystectomy and diversion. I mean, I would assume most of my colleagues, many of our fellows would achieve 4.5 to 5 hours at most for an open radical cystectomy with a conduit diversion. But 4.92 hours for a radical cystectomy and an intracorporeal diversion is really difficult. Therefore, while a large number of surgeons would qualify to be able to doing this open surgery, not as many would be competent enough to do this kind of robotic surgery. Therefore, those are my only two criticisms in terms of the study methodology and reporting. But otherwise, I think the study is a very difficult one, and they've achieved a very good study as a study. How we apply it to our practice is something all of us will then need to do at the time of interpreting whether I can do it in 4.92 hours and whether it is just as good for my patients or not. Do I really have the volume to be able to offer it? And is it worth my time and my cost to be able to offer it? So thank you both. The take-home message from the paper, of course, is that if you do robotic cystectomy, you have fewer wound-related and thromboembolic complications, and your patients stay in hospital for 2 less days. Although the overall complication rate is not different, the patients recover quicker at about 5 weeks. They are better after robotic cystectomy, but at about 12 weeks, everybody is more or less the same. That's the final take-home message from the paper. Let's move on to the next one because we are short on time. I'm going to invite the team of Ashwin and Vikas. Vikas, I think, will begin by summarizing the paper. Vikas, 8 minutes, please.
Yeah. I think my slides are visible. A very good evening to everyone. So the second article is titled, "Is Off-Clamp Robot-Assisted Partial Nephrectomy Beneficial for Renal Function? Data from the CLOCK Trial." So this article was published in BJU International in February 2022, volume 129 and issue 2. The editor of the journal is Freddy Hamdy and the impact factor is 5.969. The corresponding author of the article is Alessandro Antonelli. So guideline prioritize partial nephrectomy over radical nephrectomy for clinical T1 renal cell carcinoma. And increasingly, robot-assisted partial nephrectomy has become a standard approach for these subset of patients owing to its minimally invasive nature. The major benefit of partial nephrectomy over radical nephrectomy is the decreased risk of CKD, which might translate into lower risk of mortality over a long term. However, the degree of functional preservation after robot-assisted partial nephrectomy depends upon unmodifiable factors, which include baseline patient or tumor features, and a major modifiable factor, which is surgical technique, of which renal artery clamping has been put to rigorous investigation in past few years. To this date, we know that in the presence of normal contralateral kidney, only prolonged warm ischemia time leads to irreversible impairment of ipsilateral renal function. And whether a limited warm ischemia time in patients who have two normal kidneys and normal baseline function, whether it will produce any clinical relevant result remains debatable. And to this end, the data from various retrospective studies remains controversial. So with this background, a CLOCK trial, which is clamp versus off-clamp the kidney during robot partial nephrectomy, was designed to assess the impact of an off-clamp approach to robot-assisted partial nephrectomy. So this was a phase 3 multicentric randomized control trial. It was conducted by Italian group for advanced laparoscopic surgeon at 7 different Italian institutes, which has one designated surgeon per institute who was less than 45 years of age and had an experience of at least 100 robot-assisted partial nephrectomy, which were done both under on and off-clamp approach. So the research question and the methodology followed the Picot format for RCT. The population included patients who were diagnosed to have renal mass, which was suspicious for malignancy, and these patients were deemed suitable for robot-assisted partial nephrectomy. The inclusion criteria included patients aged between 18 to 80 years who had a normal correlation profile, whose baseline eGFR was more than 60 ml per minute for body surface area, and both kidneys were normal at medical history and imaging. The tumor stage was clinical T1 with renal complexity score of less than or equal to 10. And the patient agreed to participate in the trial and signed an informed consent. The intervention was off-clamp robot-assisted partial nephrectomy, thereby meaning the renal artery was not clamped during the procedure, and the control group was on-clamp robot-assisted partial nephrectomy. That in this group, the renal artery was clamped during the procedure. So the primary endpoint of the study was to compare the absolute variation of eGFR at 6 months. There were many secondary endpoints, which included absolute variation of GFR at 12, 18, and 24 months, 6-month rate of relative variation in GFR over 25%, and 6-month absolute variation in split renal function of the operated kidney by DTP scan. The timeline of the study ranged from September 2015 to November 2018. The random sequence for both comparative groups were generated using computer generation method using command dialog in Stata 15. Randomized allocation of the patient was done in 1:1 ratio using a permitted block design, which was stratified according to the center and according to the renal score, whether it was less than 7 or more than or equal to 7. The surgeon who were doing the surgery were informed of the randomization arm just before the surgery. However, they were allowed to change the assigned approach before or during the procedure, keeping in mind the patient's safety. Patient in both the group received a standardized care in the form of preoperative and postoperative management, and the healthcare professionals who were providing these preoperative and postoperative care were blinded of the randomization result. eGFR was calculated using the CKD EPI equation, and DTP scan was done before the surgery and after 6 months to assess the split renal function. And the nuclear medicine physicians who were doing this DTP scan were also blinded of the randomization. The surgical steps for patient in both the arms followed a strict protocol. Renal defatting and renal artery isolation were mandatorily done in both the groups. The only difference in the surgical step was that in the on-clamp arm, at least the tumor resection and the inner renal artery was done under global ischemia. And in the off-clamp arm, the renal artery had to remain unclamped throughout the procedure. And controlled hypotension during resection was not allowed in any of the arms. This was a superiority trial design, so the null hypothesis was that no difference between the group were expected, and the alternative hypothesis that a difference could be observed. So the level of significance was kept at 5%, the power of study was 80%, and a standard deviation of GFR was kept at 20 ml per minute based on previous study. And significant minimum difference was kept at 5 ml per minute. So the minimum required sample size was calculated according to the according to the formula for ANCOVA, and it was at least 102 patients in each of the groups. So continuous variables were reported in form of median and interquartile ranges, and dichotomous variable were reported in the form of frequencies and proportion. Absolute variation of GFR and absolute variation of split renal function at 6 months was compared using ANCOVA, which were statistically controlled for gender, age, tumor dimension, and renal score. Comparison of relative value of GFR more than 25% was done by multivariable logistic regression, and odds rates were estimated, which were adjusted for gender, age, tumor dimension, renal score, and preoperative eGFR. A comprehensive intention to treat and a per protocol subgroup analysis was performed for the patient, and even the heterogeneity of absolute variation in GFR difference were analyzed, keeping in mind potential confounders like diabetes, hypertension, ECOG score, Charleston comorbidity index, and renal score. P-value of less than 0.05 was considered significant, and the analysis was performed using STATA 16.1. Now the result and discussion part will be done by Dr. Ashwin.
Yeah, my slides visible?
Yeah.
Yeah. Yeah. So I'll be continuing with the results discussion and conclusion. So let me start with the consort diagram. Basically, 353 patients were assessed for eligibility, and random allocation of 324 patients was done. 160 to the intention to 160 to the on-clamp group, and 164 to the off-clamp group for the intention to treat analysis. So 17 and 23 were respectively lost to follow-up. Final analysis for intention to treat analysis was 143 for the on-clamp group and 141 for the off-clamp group. They also did a per protocol analysis because there was a significant rate of change of plan in patients, some of the patients who were allocated to the off-clamp group. So around 43% of the people were changed to on-clamp just before the surgery or during the surgery due to any bleeding. So a per protocol analysis was done for 124 patients in the on-clamp group and 79 patients in the off-clamp group. So if we see the baseline characteristics for on-clamp versus off-clamp, for both, for both the groups, the baseline characteristics of gender, age, BMI, baseline hematological characteristics, coagulation parameters, glomerular filtration rate was comparable. So was the operated kidney percentage split renal function at baseline, comorbidities, and the ECOG performance status. This was also comparable. So was the Charlson's comorbidity index. The baseline clinical tumor dimension was 3 centimeters versus 2.7 centimeters in the intention to treat protocol, and 3 versus 2.2 in the per protocol analysis. Okay, and the renal score was comparable. It was 7 and 6. So none of these had any statistically different significance. So the median warm ischemia time in the intention to treat group was 14 minutes versus 15 minutes. So intention, even the people who crossed over, they had 15 minutes off clamp. And in the per protocol group, the median warm ischemia time was 14.3 minutes and 0 minutes on clamp versus off clamp, with the interquartile range of 11 to 18. So coming to the outcome analysis. So as you can see, the absolute variation in GFR at 6 months, both in the on clamp and off clamp, did not reach statistical significance. So they had 2 statistical models. So one which compared the outcome along with the eGFR, and the other model compared the outcome with eGFR, age, sex, tumor size, and renal score. In both models, they did not achieve any statistical significant difference in results, outcomes, whether you did a off-clamp or on-clamp technique. So absolute variation in GFR at 6 months, or relative variation in GFR more than 25% in 6 months, or absolute variation in split renal function at 6 months on DTP renography were all statistically similar. So even if we are doing a per protocol analysis, we achieved the same results, wherein there were no differences in the outcome measures at 6 months that is the absolute variation in GFR, relative variation in GFR, as well as the absolute variation in split renal function at 6 months. So here you can see the box plots, which are very similar for both the on-clamp and off-clamp arms, whether it is in the intention to treat protocol or the per protocol analysis. So coming to the discussion, this study addresses whether clamping versus no clamping affects post-operative renal function. So the authors here claim that the strengths of the study to be that they had pre-operative and post-operative scintigraphy and rigorous data management. And since there were multiple surgeons in centers involved, there is increased generalizability of the results. And that whether you see the results at 6, 12, 18, and 24 months after surgery, the groups were comparable in terms of absolute decrease in estimated GFR and rate of eGFR decrease and extent of variation in ipsilateral renal function at renal scan, both in the intention to treat as well as the per protocol analysis. So in essence, if a patient has 2 normal kidneys, regular baseline function, low to moderate complexity score, renal score, and experience a limited warm ischemia time, there is no increased risk of developing post-op renal dysfunction, even with the on-clamp technique. So far, we have had retrospective studies with conflicting results and selection bias. So to overcome this, there were several studies which tried to do matched analysis, but the results have not been univocal. So those results have been retrospective, unaccounted selection bias, and no mention of conversion from off-clamp to on-clamp or vice versa, which in this study was like a real-world situation. So there have been studies in the past which are mainly retrospective and multi-institutional, which have had varied results. Some have shown no difference in the outcomes. Some have shown that there is better result of the off-clamp in the short term, but in the long term, but not in the short term. There was only one prospective randomized control trial by Anderson et al., in which they compared 71 off-clamp versus on-clamp patients, and they found that there was no difference in off-clamp versus on-clamp, which is aligned to the results of this study. So the limitations, as acknowledged by the authors themselves, are that because this is an RCT, the results could be less generalizable. But the explanation they give is that pre-op and the post-operative care was handled by separate physician teams not involved in the trial. So this study was powered on a midterm endpoint, that is around 6 months. But that seems to be a good and not a very early outcome or a very late outcome, because they were the secondary measures, that is at 12, 18, and 24. But the explanation they give is at 6 months, the functional compensation is complete and predicts the future eGFR. And there has been a not negligible rate of crossover. 43% went from being off-clamp to on-clamp. This could reduce the reliability of the intention to treat trial. But intention to treat, as we have seen in most randomized superiority trials, is the preferred approach. So crossover is expected in any RCT focused on surgical procedure, especially in this case where patient safety is involved, where there was a higher risk of bleeding. So in conclusion, this study did not show any evidence of different functional outcomes between on and off-clamp RAPN in patients with 2 kidneys, normal baseline function, and those exposed to a limited warm ischemia time, which was the median was around 14 minutes in this case. So surgeons who are performing robotic partial nephrectomy should adopt their preferred approach, regardless of the intention to improve functional preservation. I'd give it back to Vikas, Dr. Vikas, to do a critical appraisal.
Thank you, Dr. Ashwin. So, the critical appraisal for this article was done using CASP criteria for RCT, which includes a series of 11 questions distributed over 4 sections, which relates to the validity, methodology, result, and the applicability of the result. So this study clearly addressed a focused research question whether an on-clamp versus off-clamp RAPN in patient with clinical T1 renal mass produces a significant postoperative difference, which was calculated according to the absolute variation in GFR and split renal function at 6 months. The participants in both the groups were randomized and by the computer-generated random sequence, and the randomized allocation was done in 1:1 ratio by a permuted block design, which was stratified according to the center and complexity of the tumor. All the participants who entered the study were accounted for. At the conclusion, the author have clearly mentioned the number of patients who were lost to follow-up, and as well as the number of patients who cross over to the other group during the study. and a comprehensive intention to treat and per protocol subgroup analysis was done for these patients. The author has not disclosed whether the participants were blinded to the intervention. However, the investigators, the caregivers, and the people who were analyzing the outcome were blinded to the study, blinded to the intervention. The patient in both the groups were well balanced in terms of baseline feature like median EGFR, operated kidney split renal function, tumor diameter, renal score in both the groups. Apart from the experimental intervention, which included whether to clamp or not to clamp the renal artery, patient in both the groups receives the similar level of care, and the caregivers were also blinded of the randomization. Even the surgical steps were strictly regulated as by the study protocol, and renal defatting and renal artery isolation were done mandatory in both the groups. The effect of intervention has been comprehensively reported. The sample size has been adequately calculated, keeping the power of more than 80%. Primary and secondary outcomes have been clearly defined and reported in the results section. However, there were dropouts in both the groups, which have been mentioned in the study result. And there was a significant crossover of around 14% patient in the on-clamp arm and 43% patient in the off-clamp arm, which could have diluted the result. However, a per protocol and intention to treat analysis could have obviated this phenomenon. And p-values for all the analysis were reported. The confidence interval of outcomes like absolute variation in GFR has been reported. However, they could not find any significant differences in the primary as well as the secondary endpoint. The one thing is that the author has not disclosed any adverse events or complication in the intraoperative as well as the postoperative period. Whether there was, apart from the bleeding episode, whether there was need for blood transfusion or the hemoglobin drop, or whether there were positive margin. Even the cost-effective analysis has not been done in this study. So the benefit of experimental intervention over harm and cost cannot be commented upon. Now coming on to the most important aspect, whether this result can be applied in our population. So the study focused on a very limited, well-defined population of clinical T1 renal mass with renal complexity score of less than 10 with a standardized technique of surgery. Since the intraoperative and postoperative complication has not been reported, and the normal parenchymal loss which occurred due to partial nephrectomy has not been assessed in this study. And the data from previous study has shown that it is the percentage of the parenchymal volume which is preserved after partial nephrectomy, which has the strongest correlation with the functional outcome. And when parenchymal volume preservation is not integrated in the analysis, only then the value of ischemia comes, leading to the common refrain that every minute count. And when parenchymal volume changes are incorporated in the analysis, ischemia loses all its significance. And we also know that more complex partial nephrectomy requires a longer ischemia time and will substantially reduce vascularized parenchymal volume. So it remains to be seen whether off-clamp approach is even feasible, and if feasible, whether it produces meaningfully clinically relevant results in this subset of patients. So to summarize, this study is well designed and provides a level 1 data that limited warm ischemia has minimal or no effect on functional recovery after partial nephrectomy in most of the patients with small renal masses. The crossover was substantial, which includes 69 cases in the off-clamp group. However, the result of intention to treat and per protocol analysis were concordant. So the result seems legible and applicable. The study also shows that off-clamp approach can lead to potential challenges, even in this relatively low-risk population. The median ischemia time in the on-clamp group was only 15 minutes. So this trial was actually evaluating a limited warm ischemia versus no ischemia. And it remains to be seen whether when the warm ischemia time reaches a limit of 25 to 30 minutes, whether an off-clamp approach produces a significant result or not. Thank you.
Right, thank you, Vikas. Excellent, both of you. You've done a very good job with doing a critical appraisal. So I'm glad you brought up the CASP guidelines and the CASP summary, which is how a critical appraisal should be done. It's not that I like the technique or I don't like the technique, therefore I will find a reason to either support it or to abuse it. CASP is pretty straightforward. It doesn't go into the merits of good or bad. It assesses it in terms of its study design. So well done, both of you. I know that a lot of questions have been covered in the chat. You've been answering questions in the chat, but I'll still ask Aditya and Sukhdev if they want to say anything about the paper, apart from what's been said on the chat.
Dr. Vikas, I mean, what I feel, the more complex the lesion is, the more the conversion from off clamp to on clamp, right? So if they had given a proper stratification of the renal complexity scores and their off clamp and a separate substratified analysis, it would have been better. And I also, you had told that the more the parenchyma preserved, more is the proper recovery and outcome. And I feel more is the functional parenchyma which is left over, more will be the long-term, better will be the long-term outcomes. But it all depends on the orientation of the needle, hypotension, plus or minus, and reperfusion injury, whether mannitol was used or not used. Those kind of things are all important, is what I feel. I'm not sure.
So this has been proved, even the retrospective studies have shown that it is the functional parenchymal volume which is preserved, which is the strongest predictor of functional recovery, not the ischemia. So this has been proven. That is the major counter for this article.
So here I just want
to add something. Yeah, go ahead, Ashwin.
Yes, sir. If I may add something, thank you for that question, Dr. Sukhdev. But the stratification, they have not done a subgroup analysis of conversion, but I think what they have done is in both groups, the median renal score was similar. So I think, so the complexity wise, they did not have a very dissimilar group. The other thing is functional renal, whatever happens in the early months, they have looked at the results at 6 months post. So whatever issues have happened in the renal parenchyma, so either the opposite kidney has taken over or the kidney, the operated kidney has taken over the function. And I think the absolute, split renal function at 6 months is probably giving a good measure of the functional renal parenchyma that is preserved. Other thing that I wanted to add was the study done by the Cleveland Clinic group, which had Inderpreet Gill as one of the authors, showed that the Every Minute Counts article, the study was done in solitary functioning kidneys or solitary kidneys. It was not in kidneys that had patients with two functioning kidneys. So probably I would think that the take home from this is, if most of the cohort of patients that we operate belong to this kind of renal complexity, renal scores, and with a limited warm ischemia time, we should not be shy of doing a clamping. That's what I think would be what I would take home from this from this article.
All right, good, thank you. So Aditya, do you want to add anything?
I think, sir, the study was well conducted, especially they went on to complete the study despite 42% crossover rate was really commendable, and both ITT and per protocol analysis was given. My only contention was why the surgeons were less than 45 years. That was the only thing I noticed.
All of them have done 100 partial nephrectomy.
All right, excellent. So both of you have brought out what needed to be brought out. Both Vikas and Ashwin, you've done a good job of it. I've noted a few additional things in the paper, and since I read the PDF of the paper, I marked it on the PDF and I'll just highlight it. I won't share my screen, but I will just tell you what I noted. So one of the things that I noted was that in the write-up, when they talk about the intention to treat analysis in the results section, the second paragraph talks about crossover cases into account, and then they talk about patients who were crossed over. When you do an intention to treat analysis, you don't talk about crossover. You talk about crossover in the section where you're writing about the per protocol analysis. So describing the patients who were crossed over in the section where you're writing the intention to treat analysis is wrong. So there should have been no writing about the crossover cases in the ITT analysis. That paragraph should have been written in the per protocol analysis paragraph. The second question I had, and actually it's a comment on the presentation also, is that when you showed the baseline characteristic chart, you showed the ITT and the per protocol side by side, and you showed that there is no difference between the two. Now that's actually not true. When you do a randomized study, you expect the baseline to be the same. That is the whole concept behind randomization, and therefore you never give a column for p-values when you're giving the baseline characteristics of a randomized trial. The table 1 of a randomized trial where you give baseline characteristics of the two groups, you don't need to give p-values and CIs because these are randomized. However, the right side column was a per protocol analysis, which had excluded a certain set of patients from each group. Now the two groups are no longer randomized. And therefore, the assumption that the baseline characteristics of the per protocol analysis group is also the same is not true. Therefore, for example, in the tumor size, the mean diameter, it was 3 centimeter in the on-clamp group and 2.2 in the off-clamp group. Now we are assuming that they are the same, but they may not be the same because this comparison has actually not been given in that table. So the table which talks about the per protocol analysis, where you have removed some of the subjects from each arm after randomization, may no longer be comparable. And therefore, I would have wanted a comparative p-value or a CIs for those comparative. And specifically, for example, in the tumor size, 2.2 versus 3 to my mind might very well turn out to be significantly different in the on-clamp versus the off-clamp group. That was something which I noticed on the table. One more issue that I noticed was that in the intention to treat analysis, they have written that the mean warm ischemia time in the off-clamp group was 15 minutes, and the not mean, I think this was median. Median was 15 minutes, and the interquartile range was 13 to 19. Now, this is the ITT analysis. ITT analysis means everybody in that group was included. Now, 43% patients crossed over to getting a clamp, but 57% patients had zero warm ischemia in the ITT group of clamp. 57% were zero. Therefore, how did the 25% interquartile median become 13 minutes? The 25% interquartile for the median should have been zero to my mind. When you look at medians, medians is simply aligning them in either an ascending order or a descending order and looking at the middle value. If 57% had zero, up till 57%, your number should have been zero, and then it starts with variable degrees of warm ischemia time. Therefore, your median may be greater than zero. Your median may vary. In fact, the median should also not be greater than zero. Median is 50%. So median should also be ideally zero. And the 25% lower quartile should also be zero. So my feeling is that this was not the ITT results that they were giving. And this was either the group which was converted where the median was 15 and not the ITT for the whole group. So I think that is something which is also not quite correct. There were also some minor differences that I noticed in some of the tables where I think that they, for example, in the, again, the baseline table, they found that both groups had 60% as men, which wasn't actually correct. It wasn't actually 60% in both. The numbers were actually different. It was actually 60%. So summary of what I have said, now this is a critical appraisal of the article. This doesn't change what they have said. This doesn't change what their results are. The results are probably true and valid. But when you're writing an article, you need to look at all these aspects of the study. And quite possible they must have started from the European Urology, gone down to Journal of Urology, gone down to another, maybe a JAMA and an NEJM, and then come down to BJUI and where they stopped and got accepted. All of us understand that. We start at the highest order. You start with a randomized controlled trial in a surgical specialty. It is so rare that I would be assuming it would get published in an NEJM or a JAMA with an impact factor of 100 plus today. So the fact that it has come down means somebody's picked up these minor issues. And if you hadn't got these minor issues, you might very well have got accepted at a journal which had 3 times the impact factor than what the BJUI does. BJUI has 5, it's very good. But you might very well have got a European Urology. And it's possible some of your reviewers picked up some of these smaller issues, which says that you haven't been very careful in how you wrote that paper. So excellent work, both teams. I think you've done a great job. I mean, you weren't teams, you weren't competing, but you've done a great job, all of you. I'm going to close at this point of time from my side. We're about 10 minutes over time. I'm going to hand it over to Ravi.
Thank you, sir. It was a wonderful, I think, experiment, as Dr. Ghosh mentioned in the beginning talk, that probably a prototype of how a journal club should be conducted and how it should be analyzed. And I can see the audience, they are thoroughly, completely glued from the time they have logged in till now. So that's wonderful. And being a secretary of the subsection, I have this honest submission that please try to register yourself both for the membership as well as for the annual meeting. Now it's in Delhi, so probably travel is not an issue, and it's on 9th and 10th of June. So this was our 5th webinar. Now in the 6th webinar, it would be on 24th of April, that is Monday. Moderators would be Dr. Harshit Garg. Many of you would know him. He is an alumnus of AIIMS and will be finishing his fellowship at MD Anderson in this June. So he has worked very closely with the pioneers who conducted SWOG and keynote trials. So he would be delivering on adjuvant treatment options in bladder cancer, and Dr. Ganesh Bakshi would be doing the case discussion, panel discussion after that. So with that, I again request you, everyone, to kindly register both for the section as well as for the annual conference. And for those to encourage residents who have not participated today, I would request every one of you to actually encourage them to go to the USI TV. This entire thing is available as a recorded format, because it's a very nice learning exercise how to critically analyze an article. And I congratulate all the 4 speakers and Raju sir as usual to bring up very important points. Thank you very much and good night. Thank you. Good night, sir.
Thank you, sir.